All right, let's get right into it. Today, we are tackling a really critical diagnostic challenge in cardiology. We're looking at two conditions that can sometimes look deceptively similar on an ECG, but are worlds apart: Wolff-Parkinson-White syndrome and Brugada syndrome. One's a problem with the heart's wiring, the other is more like a glitch in the system. So, let's figure out how to tell them apart.
Okay, so picture this. You've got an ECG in front of you. You know that one heart has a secret electrical shortcut, and the other has a really dangerous hidden glitch. Both of them can lead to some pretty serious arrhythmias, so telling them apart isn't just academic. It's absolutely critical. The question is, how do you do it? How do you spot the difference? Well, let's crack this case together. So let's open the file on our first suspect, Wolff-Parkinson-White syndrome, or WPW for short. The whole story here is about the path the electricity takes to get through the heart. It's all about the route. The key concept you gotta understand for WPW is pre-excitation. So think about the heart's normal electrical signal, right? It's supposed to pause for a fraction of a second at the AB node, kind of like stopping at a red light. This gives the ventricles time to fill. But in WPW, there's this extra wire, an accessory pathway, that lets the signal just blow right past that red light. It gets to the ventricles early, hence pre-excitation.
And this is the perfect way to think about it. That accessory pathway, which is called the bundle of Kend, is literally an electrical shortcut. And just like taking a shortcut in traffic, it completely changes the timing and the whole look of the journey. And that's exactly what we end up seeing on the ECG.
So how does this shortcut actually show up on the tracing? Well, it leaves behind three very distinct clues, a classic triad. First, you get a short PR interval. And that makes perfect sense, right? We're bypassing the AV node's delay, so that interval gets shorter. Second, you get the famous delta wave. This is a slurred upstroke at the beginning of the QRS complex. It happens because the ventricle starts to depolarize early from that shortcut, creating this slow, slurred beginning before the normal conduction system kicks in. And third, all of this leads to a wide QRS complex, because you've got this fusion of the early abnormal activation and the normal activation happening at the same time.
Okay, now for our second suspect, Brugada syndrome. If WPW is a problem with the heart's wiring map, like a road map with an extra road, Brugada is a problem with the wires themselves. It's a totally different kind of issue. Brugada is what we call a channelopathy. It's a big word, but it just means that the tiny little pores on the heart cells, specifically the sodium channels, are not working right. There's no secret shortcut, no extra pathway here. The problem is with the fundamental hardware of the cells. But, and this is key, it's usually only in one specific region of the heart. And a great way to visualize this is as a localized power glitch. Imagine the rest of the heart's electrical grid is humming along just fine, but in one neighborhood, specifically the right ventricle, the power is unstable and glitchy. It's this instability that creates a very, very different and dangerous signature on the ECG. So here's what that glitch looks like. First, you're only going to see these clues in very specific leads, V1, V2, and V3. Why? Because those are the leads that are looking right at that affected area of the right ventricle. The key sign is a very distinct ST segment elevation, often with a shape that looks like a right bundle branch block. Now notice what's missing. This is so important. There is no delta wave, and there is no short PR interval. The timing isn't early like in WPW, it's just dangerously abnormal. Now, Brugada's ST elevation can have a couple of different looks, but the one that absolutely clinches the diagnosis is type 1. What we call the coved pattern. It literally looks like a ski slope, arching down into an inverted T-wave. The other types, the saddleback patterns, are definitely suspicious, but they're not diagnostic by themselves. That coved shape, that's the smoking gun. All right, we've interviewed both of our suspects. We've got their stories. Now it's time to put them in the same room, side by side, and do a head-to-head comparison. This case file really lays it all out, doesn't it? Let's break it down. The primary mechanism? It's a shortcut versus a glitch. The QRS morphology? A slurred delta wave in WPW versus a block pattern in Brugada. The PR interval? Short in WPW, but typically normal in Brugada. And the ST segment? This is a big one. In WPW, any ST changes are just a secondary result of the weird depolarization. But in Brugada, that ST elevation is the primary problem. And finally, location, location, location. WPW can show up in lots of leads, but Brugada's signature is hiding specifically in V1 through V3. But here's the twist in our case.
Just when you think you've got them figured out, you learn that these culprits can be masters of disguise. The classic patterns, well, they aren't always there on a routine ECG.
The Brugada pattern can be really tricky. It comes and goes. An ECG could look totally normal 1 minute, but then the pattern can be dramatically unmasked by things like a fever, certain medications, or even just an electrolyte imbalance. This means a normal ECG today doesn't rule it out if you have a high clinical suspicion.
And WPW has its own tricks. The pattern can just be intermittent. Or you can have this super sneaky variation called concealed WPW. In this case, the shortcut is like a one-way street. It only lets signals go backward, from the ventricles up to the atria. Because it can't go forward, it doesn't cause that telltale pre-excitation on a resting ECG. It looks completely normal, until it suddenly triggers an arrhythmia.
So we've sorted through all the evidence, we've seen the disguises, we've avoided the red herrings. At the end of the day, what is the one single thing that helps us make the final call? It really all boils down to this simple visual mnemonic, and if you remember one thing, remember this. The shortcut in WPW creates a slur. That's your delta wave. The glitch in Brugada creates a slope. That's the coved ST elevation. A slur versus a slope. It's really a powerful way to visually separate these two critical diagnoses, even at a quick glance. And that really brings us to the most important point. These aren't just squiggles on a piece of paper. They're patterns that tell a crucial story about a heart that's at risk. Recognizing the difference between a shortcut and a glitch, between a slur and a slope, it's more than just an academic exercise. It's about seeing the one clue that could save someone's life. The real question is, when that pattern is on the page in front of you, will you be ready to solve the case?